Good morning, everyone. Welcome to Grand Rounds. So it's my pleasure to introduce Dr. Elizabeth Courville today. And so Elizabeth's only been with us 3.5 years, but she's been uniformly outstanding in every way. So Elizabeth was the first faculty member that we hired in 2013, but it was the first search committee I had the privilege of being on. And what was kind of cool about it is that it was the first time we tried electronic applications. And so we got like at least 50 applicants, but I mean, Elizabeth clearly rose to the top. And we interviewed a lot of people, but she was our number one choice. And fortunately, she really liked us and came here. So Elizabeth grew up in Ohio, but she went to Dartmouth for medical school. She did a post-sophomore fellowship there and really had a lot of great experiences. She interviewed for our residency program, but elected to go to the Massachusetts General Hospital. So she got really just outstanding APCP training and then completed a prestigious HemePath fellowship here. So Elizabeth, I really think that she's a triple threat. If you look at what she's done since she's been here 3.5 years, which is a substantial time, but she's really accomplished. So if you look at what she's been able to accomplish in terms of clinical service, she brings gifts to our service by her expertise. I mean, she had this really pedigreed HemePath morphology training that really complements our knowledge base. She came and is really an effective leader as an associate director of the Flow Lab and also as the medical director of the Maple Grove Clinical Lab. And she gets a lot of remarks and praise for her education. So she received a teaching award last year from the residents. And even one of the residents told me that they initiated a research project with her, and I think this is the best example of mentorship. Elizabeth sat down with the first-year trainee and said, okay, let's do a project together. Here's my outline for it. Here are all the steps. Here are the due dates. And we all know that Elizabeth is going to start a project with the resident, get it to publication, and get it through the door. And finally, she's a scholar. So she's only been here 3.5 years. And since she's been here, she's published, not just submitted. She's published more than 20 publications. And a substantial amount of them are first or last author. She's usually the senior author. She's leading a medical student, a resident, or fellow. And they're really nice original work. So today she's going to give us a talk about pathology of post-transplant lymphoproliferative disorders, current state of knowledge and future affairs. And so Elizabeth, I welcome you, and I'm really proud to call you a colleague.
Thank you, Mike. That's a very kind introduction. And I am just going to go ahead and get started because I do have a lot of things that I want to cover. As Mike said, I'm going to talk about post-transplant lymphoproliferative disorder today, and that is abbreviated PTLD. I have no disclosures. And just to go over my objectives, I actually have some pretty broad picture objectives here. What I want you to walk away with is I want you to appreciate the complexity of the immune system and the lymphoproliferative disorders that can arise from the immune system. I want you to really appreciate and understand that there is a spectrum of presentation of post-transplant lymphoproliferative disorder. And what I would be really happy about is if you walked away here beginning to generate your own questions and having your own ideas about PTLD and where we should go in future directions to learn more about PTLD. So just to start with a little bit of an introduction. The immune system is really a complex and intricate system with a variety of cells and molecules that our body uses to defend against infection. We usually divide it into the innate immune system and the adaptive immune system, or the adaptive immune response. And that adaptive immune response is dependent on antigen-specific proliferation of B and T cells. This proliferation of that adaptive immune response mainly occurs in lymph nodes and secondary lymphoid organs such as the spleen, mucosa-associated lymphoid tissue. And these are just two diagrams showing the lymph nodes, secondary lymphoid tissues, and the associated lymphatic system. It's very important for pathologists, both hematopathologists and surgical pathologists, to know the normal architecture of the lymph node. It's important mainly so that we can recognize when something's abnormal, when something doesn't fit in the normal architecture. So just to go over the normal architecture of a lymph node, this is obviously a diagram, not a real picture. But if we start at the outside and we move in, the outer portion of the lymph node is defined by a capsule, collagenous capsule, and just under that you have a subcapsular sinus. The first layer of lymphoid tissue we call the cortex, and this is where the follicles are. Follicles are made predominantly composed of B cells with fewer T cells. We have primary follicles and then secondary follicles. Secondary follicles are defined by having a germinal center. The inner follicular region in the cortex, which is the area in between the follicles, is predominantly T cells, some plasma cells, some histiocytes. If we move further in to the lymph node and we go to the paracortex, which is what we call the next layer, that's similar in composition to the interfollicular region. Lots of T cells, lymphocytes, T lymphocytes, plasma cells, histiocytes. Moving down to the medullary cords, these normally has a lot of plasma cells. Is just a normal composition. And then down into the hilum. When lymph flows through a lymph node, it starts out here in the capsule with afferent lymphatics, flows through the lymph node, and then exits through the hilum through efferent lymphatics. That was a diagram. In real life, things don't always line up exactly right, but here's an example of a lymph node that has a normal architecture. We see the perinodal fat or adipose tissue, which usually does not have lymphocytes within it. Here's that capsule, the subcapsular sinus. Here's the cortex, and we see secondary follicles with germinal centers. This is probably a primary follicle. Down into the interfollicular region, going into the medullary sinuses, and down towards the hilum. Nice normal lymph node. Here's another picture. We can tell this is a nice normal lymph node. Also, the follicles, or the germinal centers, have nice benign features. They're polarized, tingible body macrophages. They're surrounded by nice mantle zones, and they're respecting each other's boundaries. So, given the complexity of the immune system, with the variety of cell types that it utilizes, it's really not surprising that the lymphoproliferative disorders and lymphomas that arise from this system are complex and present with a variety of phenotypes. And this is something we're still learning about, and we're still expanding our knowledge about the different types of lymphomas and lymphoproliferative disorders. A certainly simplistic but still helpful way to think about lymphomas is kind of this traditional scheme, and this is, I think, what a lot of clinicians think about. And that's to define lymphoma into a couple big picture boxes. You can have either Hodgkin lymphoma or non-Hodgkin lymphoma. Among the non-Hodgkin lymphomas, we have B or T cell lymphomas, and then they're either small cells or large cells. Like I said, that's helpful and a helpful way to organize things, but things are really much more complex. The real world is much more complex. In HemePath, what we use as our guide when we're making diagnoses is the World Health Organization classification of tumors of hematopoietic and lymphoid tissues. The latest edition was 2008, and there will be updates called the 2016 updates or revisions to that. And we use this on a daily basis. We reference it a lot because there are a lot of different entities. There are over 30 different diagnoses that you can make within lymphoid disorders currently. Okay, so this is complex. So non-Hodgkin lymphoma, and this is how it's collected in epidemiologic data as non-Hodgkin lymphoma, represents about 4% of new cancer diagnoses a year in the United States. And a quarter to a third of those are diffuse large B-cell lymphoma. So I'll take some time to talk more about diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is a clonal neoplasm composed of mature B lymphocytes. These lymphocytes form sheets, and they're sheets of intermediate to large-sized cells. Okay. That efface that normal architecture. Before you make a diagnosis of diffuse large B-cell lymphoma, there are other things composed of intermediate to large-sized B cells that you need to keep in your differential. and those are listed there. You need to exclude those other lymphomas of large B cells. You can do that based on morphology, immunophenotype, patient characteristics, location of the lesion, association or not with particular viral entities. Okay. Once you've excluded those other entities and you're within diffuse large B-cell lymphoma, there are subtypes of diffuse large B-cell lymphoma. These are based on their morphologic appearance as well as some characteristic locations where they occur. For example, T-cell histiocyte-rich large B-cell lymphoma is a subtype of DLBCL. We have primary DLBCL of the central nervous system, primary cutaneous DLBCL leg type, those last two defined by location. And there's the entity EBV positive DLBCL of the elderly. This is the classification as per the 2008 WHO. For those of you who are curious, there will be some changes to this. For the 2016 revision, in particular, there's a new entity of EBV positive mucocutaneous ulcer that will be introduced as a professional subtype of DLBCL. And some of the, what we used to call gray zone cases, will be given some new nomenclature. So let's look at some pictures of diffuse large B-cell lymphoma and what it looks like. So here in this low-power picture, we see a effacement of the nodal architecture. There's none of that normal nodal architecture that we went over. We have sheets of atypical lymphoid cells. And if we look at higher power, we can see they're intermediate to large in size. They have vesicular chromatin, and they have prominent nucleoli. It's not uncommon in these lesions to find frequent apoptotic bodies, frequent mitotic figures. Here's a stain for CD20, and we see these sheets of atypical lymphoid cells are CD20 positive, indicating B-cell lineage. Okay. Now, no hematopathologist can ever do just one immunohistochemical stain, and so we would definitely do many more stains. I'm not going to show them all for this case. Now, for our case, if you were an expert hematopathologist at the University of Minnesota, this is how you would sign this case out. You would exclude all those other entities in your differential of a large B-cell lymphoma, and we say this is diffuse large B-cell lymphoma, not otherwise specified. Overall, the morphologic and immunohistochemical findings are consistent with DLBCL, not otherwise specified. This case, additional stains show that it had a germinal center immunophenotype by the Hans criteria. We request that you please correlate with separately reported FISH results, and MYC immunohistochemical stain is negative. To go over a couple of the things that Dr. Linden so nicely commented on, germinal center immunophenotype by the Hans criteria. So for DLBCL not otherwise specified, a prognostic marker or indicator is how it stains by what's called the Hans criteria. It's using CD10, BCL6, and MUM1. We decide if the DLBCL falls into a germinal center or a non-germinal center category, with the non-germinal center having a worse prognosis in most studies. So that's the staining that we do. For all cases, new diagnoses of DLBCL, we do have requests that FISH be performed, looking for translocations or rearrangements in the MYC, BCL2, or BCL6 genes, as rearrangements in MYC occur in a subset of cases of DLBCL and portend a worse prognosis, particularly when there's also a rearrangement of BCL2 or BCL6. MYC immunohistochemical stain is also a stain that we use for potential prognostic purposes. So a subset of cases of DLBCL will be MYC positive, and these are thought to have a worse prognosis than cases that are MYC negative. This is an example of that Hans algorithm using 10, BCL6, and MUM1 and how we decided if it's germinal center or non-germinal center. Now, what about flow cytometry? In HemePath, we really like our immunostains and we really like our ancillary studies, so we can really bolster our diagnosis. Well, in this particular case, we see here a couple of flow plots. I just pulled out a couple. Here we're getting on our viable cells. We're pulling out our B cells. They're 19 and 20 positive. And then if we take those B cells, we have a mixture of kappa and lambda. Okay. This is not that surprising. Diffuse large B-cell lymphoma, depending on your panel in the lab where it's being performed, up to a quarter or a third of those cases may not be able to detect a clonal B-cell population by flow cytometry. And that's due to a variety of reasons. And that's why, if you're an expert hematopathologist at the University of Minnesota, this is how you would sign this case out. We say what we see, which is polytypic B cells, but we always put that caveat that this assay may miss neoplastic cells. So those cells may be lost in processing or not be sampled. Okay. Going back to our case, we get the FISH results back. They're normal in that there's no evidence found of rearrangement of the MYC, BCL6, or BCL2 loci. So this case that we just showed, diffuse large B-cell lymphoma not otherwise specified with a germinal center immunophenotype by Hans criteria and no association with MYC rearrangement. Prognosis in diffuse large B-cell lymphoma is dependent on many factors. Many of them are clinical factors, such as the patient age, presence of comorbidities, and the stage of the disease. There are also some prognostic factors associated with the lymphoma itself, and this is an area that we're learning a lot more about. Maybe about 15 or so years ago, people used gene expression profiling to divide cases of diffuse large B-cell lymphoma into those that resembled normal B cells of the germinal center and those of activated B cells. And the activated B cell, those that had the activated B cell gene expression profile had a worse prognosis. At least currently, gene expression profiling is not used in a clinical basis, and instead what we use as a surrogate for that are immunohistochemical algorithms. The most common one used is the Hans algorithm that I alluded to before. Okay, so that's one thing we use for prognosis in terms of characteristics of the lymphoma itself. Another thing I also alluded to already are the MYC, BCL2, and BCL6 rearrangements. Somewhere in the order of 10 to 15% of DLBCLs can have a MYC rearrangement, and many of those have BCL2 and BCL6 rearrangements as well. We refer to those as double or triple hits, and they also carry a worse prognosis. Somewhat less well established is the idea that if you have MYC positivity by immunohistochemistry, but you lack the MYC rearrangement, if that portends a worse prognosis. And there's a thought is it probably does, but possibly only in the context of BCL2 overexpression. And those with MYC positivity and BCL2 positivity, some people refer to as double expressors. CD30 has been investigated as a prognostic marker in DLBCL, and at least one study has shown better prognosis in DLBCL cases that were CD30 positive. I think it's actually more important in the context that we have targeted anti-CD30 therapy now. Similar to rituximab is anti-CD20, we have brentuximab, which is anti-CD30. The presence of TP53 mutations, as well as corresponding P53 overexpression, has also been studied in the context of diffuse large B-cell lymphoma, with some evidence for a worse prognosis in patients that have either TP53 mutations or P53 overexpression by immunohistochemistry. I'm going to take a little sidebar here and talk about the University of Minnesota experience with the MYC immunohistochemical stain. So very shortly after I started here, Rob McKenna asked me, well, what immunostains would you like to see here at the University of Minnesota? Is there anything that you had at MGH that you think would be helpful here? I said, well, we were using MYC. We had just brought MYC online, and that was, that was something we used, and we thought it was helpful. So I said, okay, why don't you talk to Dr. Moralt over at the IHC lab and see if we can get that going. So I mostly just kind of helped Mana and Karen Daniels, who's the lead tech over in the IHC lab, to bring the MYC IHC stain online. So that took from about January 2014 to March of 2015. Like I said, it was mainly the work of Mana and Karen. I did provide some help with finding validation cases, making sure the protocol was in place, et cetera, but it's all their hard work. So, but it came online, in about March of 2015, and we started using it on a regular clinical basis. Okay, so just about a year ago, I took a look at our last 10 months, the first 10 months of use of the MYC IHC stain. So I found that it was ordered. This is all actually throughout all the Fairview system. We can search that way. It was ordered on 56 specimens. Interestingly, 11 of them were not large B-cell lymphoma cases, so they were used in a way that wasn't really intended to be used. That was kind of interesting as an aside. Of the 45 large B-cell lymphoma cases that it was used, they were in that 10-month period. This is how they were interpreted. So we used 40% as a cutoff to call it positive or negative. And you can see just under half were negative, just under half were positive, and then a not an unsubstantial number were considered equivocal. And interestingly, we do have corresponding cytogenetics for a lot of these, because that is our protocol to send for FISH as well in these cases. Okay. Now we're in 2017. We now have almost 2 years of retrospective data on this MYC immunohistochemical stain. Just started a new project that I'm really excited about. It's with Megan, with a lot of help from Brian. And what we're going to do is retrospectively evaluate that MYC staining over that 2-year period. I want to do it both retrospectively and what we call manually, actually when I look at it under the slide to score it, and then using scan slides and some image analysis software. So we want to compare the different methods of IHC evaluation, compare it to the cases that we have cytogenetics results, and then possibly look at some clinical outcomes. Okay. So hopefully this will give us some information, and some of the questions that are out there in the literature, specifically about MYC IHC, are pretty big questions. And if we could help answer those questions, it would be really great. And so kind of the big questions out there in the literature about MYC IHC and DLBCL is, how should we use it? Should it be used as a screen for which cases should be fished for a MYC rearrangement? That's a question. In some places that don't have the resources to do FISH in every single new DLBCL, can we use MYC to screen for those? And then, is it really an independent prognostic marker outside of a MYC gene rearrangement? And that's still a question. Okay. So finally, we're actually getting to the title of my talk, which is that we're going to talk about post-transplant lymphoproliferative disorders now. Okay. I guess any questions before we move on? Everybody kind of doing okay? Makes sense? Okay. So what are post-transplant lymphoproliferative disorders? And this is one that the name really says it all, and if you break it down, you'll never forget what PTLD is. So they're post-transplant. These develop as a consequence of immunosuppression in a recipient of a solid organ, bone marrow, or stem cell allograft. They're lymphoproliferative, so they're lymphoid or plasmacytic proliferations. They're disorders, so they have the potential for morbidity and mortality. And there's an S at the end, lymphoproliferative disorders, because they comprise a spectrum of morphology. It's not just one entity. Okay. These are not very common. This is actually quite rare. So among the transplant population, which compared to the whole population is a quite small population, the overall frequency is less than 2%. A patient's risk for PTLD depends on many factors, including how long after their transplant they are, the patient age. A lot depends on the type and degree of immunosuppression they've received, as well as their infection history. And by that infection history, it's mainly whether they've been exposed to EBV in the past before. And that's because most cases of PTLD are associated with the Epstein-Barr virus infection. And most, but not all. Okay. The WHO divides cases of PTLD into multiple diagnostic categories, and that's listed here. I'll go over each of these. So early lesions of PTLD are characterized by architectural preservation of the lymph node or the involved tissue. So remember that nice normal architecture I showed you? In early lesions of PTLD, it should retain that normal architecture. Most cases do form lymphadenopathy or a extranodal mass lesion. The patterns that we see in early lesions are variable. They're most commonly, what's called plasmacytic hyperplasia, which is when you have too many plasma cells. Okay, these are polytypic plasma cells. You can have something that's called an infectious mononucleosis-like lesion, and this is changes in the lymph nodes such as follicular hyperplasia, expansion of immunoblasts in the paracortex, and it really looks like a new first-time EBV infection. There's also a third pattern in these early lesions that most people accept, maybe not all, and that's when you have florid follicular hyperplasia. These early lesions are almost all associated with EBV infection. Okay. Next, we have what's called polymorphic PTLD. This is different from the early lesions that you actually have architectural effacement of the lymph nodes, or you form destructive extranodal masses. And that effacement is caused by polymorphic mixture of cells. So you have plasma cells, lymphocytes, and lymphocytes of variable sizes. You can have atypia, necrosis, numerous mitotic figures, but importantly, it does not fulfill the criteria for one of the lymphomas we would diagnose in an immunocompetent person. Okay. Here's an example of that. These, we don't have a whole lot of cases of this. Here's one example, and you can see we do have some architectural preservation with sinus histiocytes, sinuses preserved, but there's at least partial architectural effacement here. We don't see the normal follicles. And if we look closer, there really is a mixture of cell types or a polymorphous infiltrate, and we really have a spectrum of size of those lymphocytes. These are almost always EBV associated. They may or may not be able to detect a clonal population. Classical Hodgkin lymphoma, like PTLD, is the easiest one to describe. It should fulfill the criteria for classical Hodgkin lymphoma, except it's occurring in a post-transplant patient. These are not very common. Monomorphic PTLD are cases that if you were to see it in a non-transplant patient, you would call it lymphoma, except it's occurring in a transplant patient. Okay, so it has to fulfill the criteria for a B cell or TNK cell neoplasm in an immunocompetent host. These are most commonly of B cell lineage, most commonly DLBCL. You can also see ones that look like Burkitt lymphoma or a plasma cell neoplasm. Less commonly, they're of T cell origin. PTCL, hepatospleenic T cell lymphoma. There are others. These are fairly rare. These T cell lymphomas are usually not associated with EBV, and they don't have a very good prognosis. There is one exception, just to keep in the back of your mind. Indolent small B cell lymphoma, such as a follicular lymphoma or chronic lymphocytic leukemia, does not qualify for PTLD. So that's an exception. So it's going to show a picture. They're not very common, but I did see one case of a plasma cell myeloma that arose out of in a post-transplant patient. So I had to show a picture of it because they're not very common. Okay. Now remember the new provisional entity that I mentioned that's coming in the 2016 revisions, called EBV positive mucocutaneous ulcer. This is going to be a provisional entity in the under diffuse large B-cell lymphoma. This was first described out of Elaine Jaffe's group, and some patients have been identified that have lesions involving their skin or a mucosal site, such as the oral pharynx or the GI tract, and they have a lesion that has an ulcer. Underneath the ulcer is morphology that looks like a large B-cell lymphoma, and these are EBV associated. These cases occur in patients who either have iatrogenic immunosuppression or age-related immune senescence. These were important to recognize because some of these patients responded quite well to pretty conservative management, such as this backing off on their immunosuppression. And that's what this picture is showing, is one patient at multiple time points. We see the large lesion, ulcerative lesion on the skin, that then goes away with just backing off on the immunosuppression. Okay, so EBV positive mucocutaneous ulcer. And the reason I'm bringing that to your attention is from this group, we found, or before I came here, people here found that these EBV positive mucocutaneous ulcers can occur in organ transplant recipients. And it's important to keep in mind, again, because of that, can have that more indolent course. Okay. So that would be considered perhaps a subtype of a monomorphic PTLD. Okay. Okay. Let's do a case example of a monomorphic PTLD. Okay. Let's start with the flow. This time, sometimes we do get flow data before we have morphology data, not uncommonly. In this case, I have limited flow plots. The abnormal population is in purple. They have a little bit increased forward scatter, so they're a little bit larger. I'll tell you they were 19 and 20 positive, so they were B cells. And in this case, we did pick up a clonal population. They're lambda restricted. If you were a smart hematopathologist at the University of Minnesota, this is how you would sign out the flow. Lambda monotypic B cells. Other flow plots show that they did express CD10. We mentioned the increased forward scatter, and we say please defer to morphology. This is what the morphology looked like. We have effacement of that normal nodal architecture, right? There's nothing that looks normal there. And we have some areas of pink, which are indicative. If you go on higher power, it's actually necrosis. We have some geographic necrosis in this lymph node. Sheets of atypical large cells, irregular nuclear contours, prominent nucleoli. Okay, we're getting the hang of this. CD3 positive T cells in the background that are small. Most of those large atypical cells are CD20 positive B cells. The Ki67 indicates a very high proliferative index in this case. And we have an EBV stain. So how we look for EBV currently is using actually in situ hybridization. And so it's an Eber stain. And that blue, I hope it shows up, with the pink counter stain is what we're looking for. So the blue indicates this is an EBV positive lesion. So if you were a smart hematopathologist at the University of Minnesota, this is how you would sign this case out. Monomorphic post-transplant lymphoproliferative disorder, parentheses diffuse large B-cell lymphoma, comma, EBV positive. And in the comment, we're going to just lay out our thinking. In this patient with a history of renal transplant, the morphologic and immunohistochemical findings are consistent with PTLD, has the morphology of DLBCL, and is EBV positive. Okay. I just want to say a word on PTLD treatment. Beyond my scope of my expertise and beyond the scope of this talk, but it is important to know it's different from de novo DLBCL. DLBCL in an immunocompetent patient is usually treated, depending on the stage, on 3 or 6 cycles of chemotherapy, R-CHOP. That's pretty standard. May or may not be followed by localized radiation to a particular site. PTLD treatment is different, and the treatment depends to a certain extent on this morphologic subtype. A subset of cases of PTLD, usually the early lesions, maybe some of the polymorphic lesions, respond just to reduction in immunosuppression. Another subset respond just to rituximab. Another subset do require additional chemotherapy beyond rituximab, anti-CD20 therapy. Okay. Remember I said most cases of PTLD are associated with EBV. That's entirely true. A subset are EBV negative. The actual subset, actual number, depends on the study you look at, but it's maybe about 1/3 of the cases are EBV negative. Okay. What do we know about EBV negative PTLD? It's more common in adults. It tends to occur later after transplant. It is more likely to be a monomorphic PTLD, and in general, it tends to have a worse outcome than EBV positive PTLD. That may be because they're more likely to be monomorphic, and they're more likely to be those T NK cell neoplasms that just have a worse prognosis in general. There are not a lot of studies that have looked just at EBV negative monomorphic B-cell PTLD, just zeroing in on that monomorphic B-cell PTLD group. But those that have been done, so gene expression profiling showed that these EBV negative monomorphic B-cell PTLDs segregated from the EBV positive, suggesting that they're different entities, where there are differences in their gene expression. EBV negative are more likely to have a germinal center immunophenotype. There may or may not be a difference in survival when you just zero in on those monomorphic B-cell PTLDs. It's noted that it's important to still recognize these as PTLD, however, because a subset do respond to reduction in immunosuppression. And that's the way we even bother to separate them and call them PTLD, is because there is some difference in their behavior. So believe it or not, I did not encounter very much PTLD during my training, like very, very little. I'm not sure I even saw one case. So when I came here and started to see a lot of them, I kind of had to learn on the job, and I did a lot of reading, and I did a lot of thinking. And as I did the reading, I had a lot of questions. And here are a couple of them. So one is, are these prognostic indicators that we use in de novo DLBCL, or DLBCL arising in an immunocompetent host, does that apply to monomorphic PTLD that looks like DLBCL? And then another question I just think is really interesting is, what do we really know about these EBV negative monomorphic PTLDs? It's such a fascinating subgroup of cases. So I thought, and I talked to some of my colleagues at MGH, including Dr. Sohani, who gave ground rounds last year, Dr. Ferry. I talked to some of my new colleagues here, Dr. Yohe and Dr. Nelson, and we came up with a project. We found 32 cases of B-cell monomorphic PTLD between the University of Minnesota and MGH. Okay. We excluded mucocutaneous ulcer cases and cases that were primary to the central nervous system. We made sure the following stains either had been performed or we performed them for the purposes of this study. EBV, P53 in the MYC IHC, CD30, BCL2, the 10 BCL6 and MUM1 for the Hans criteria. We used chart review to look at clinical data, looked at morphology and the immunohistochemical stains. Flow we got from the original reports. FISH and cytogenetics data we got from original reports. A subset of the MGH cases, they performed FISH retrospectively. They were able to do that at MGH for some of the cases. And we did TP53 mutation analysis here on both the University of Minnesota and MGH cases. It's great, we're able to do it retrospectively. And so that was done on formalin-fixed paraffin-embedded sections here. Okay. We had 13 females, 19 males, median age of 44 with quite an age range. We had 9 pediatric patients. The latency median was 71 months with, again, quite a wide range. We had 10 post-PTLDs or early, so within a year after transplant. Most of them were solid organ transplants. 5 were hematopoietic stem cell transplant patients. 5 had localized disease. The rest were systemic. A subset of the patients had a EBV viral load obtained in the peripheral blood about the same time as the biopsy. And then 15 of those had an EBV DNA detected. In terms of morphology, most of the cases had the morphology of DLBCL, with only 3 Burkitt lymphoma cases. And matching the literature, about 70% of our cases were EBV positive. Here's just an example of some additional immunostains that were done for the purposes of this study. This is the Hans criteria showing a non-germinal center immunophenotype based on CD10 negativity, BCL6 positivity, and MUM1 positivity. Example of some other additional immunostains. So this was a MYC positive case with greater than 40% positive staining. P53 was negative with less than 30% staining. BCL2 was positive, CD30 was positive. Okay. When we compared looking at our EBV negative versus our EBV positive cases, the EBV negative cases were more frequently CD30 negative and of germinal center immunophenotype. That's not entirely surprising. We know there's association with EBV and CD30. What was surprising is the EBV negative cases were more frequently P53 positive IHC. Okay. And we subsequently did the TP53 mutation analysis. All the tested, we were not able to test one of the cases, so all the tested, 9 out of 9, of the EBV negative cases harbored a TP53 mutation. That's in contrast to only 2 of the 15 tested EBV positive cases. Okay. Looking at other differences between the EBV positive and EBV negative cases, the EBV positive cases were more likely to had a shorter latency. That's not unexpected. They did have a shorter latency, and the patients were less likely to have received chemotherapy. So all the EBV negative patients ended up receiving chemotherapy. Some of the EBV positive patients were treated with rituximab alone. Now what about MYC, BCL2, and BCL6 rearrangements? So we were able to, 12 cases in total were looked at for a MYC rearrangement. It was a MYC rearrangement was identified in only 2 of those evaluated cases, and both of those were Burkitt lymphoma cases. Okay. BCL6 or BCL2 rearrangements were looked for in only 5 cases, but were not detected in any of those 5. We did try to look at some survival factors. So looking at overall survival based on immunohistochemical parameters, those listed, or clinical factors, and found no difference in overall survival. We found no difference in overall survival based on the TP53 mutation status. Okay. There's not a whole lot of literature, there's very little literature on these prognostic factors in the context of PTLD. But there is one study with a good number of cases that also showed that germinal center versus non-germinal center immunophenotype does not appear to have prognostic significance in the context of PTLD, post-transplant DLBCL. So how do we do answering my questions? The prognostic indicators that we use for de novo DLBCL, at least with the limited studies, it does not appear to apply to PTLD, post-transplant DLBCL. But of course, more patients are needed with more standardized treatment. And interestingly, MYC rearrangement does not appear to be a dominant driver in PTLD. And what about this EBV negative monomorphic PTLD? Well, TP53 mutation really could be an important step in the pathogenesis of EBV negative PTLD. And it appears to differ from the EBV positive PTLD. Okay. This was just published at the end of last year, if anyone wants to look up the reference. So while I was doing that study, while we were working on that study, I kept having other thoughts, like I usually do. And I started thinking about the primary CNS PTLD cases that we excluded from that original case series. And so with the help of Andrew Sundin, who was a University of Minnesota medical student, we looked at those cases. So some questions I had. How differently does primary CNS PTLD stain from and look and act from systemic PTLD? And how differently does it stain and look and act from primary CNS lymphoma in a immunocompetent patient? There is a literature about CNS involvement in PTLD. It's about 10% of the PTLD cases have CNS involvement. Fewer than those do not have any systemic involvement, so would be considered primary CNS PTLD. Any CNS involvement is considered a poor prognostic indicator. CNS PTLD is associated with renal solid organ transplant, monomorphic morphology occurring later after transplant, and with EBV positivity at a higher rate than systemic PTLD. Okay. So in this case, or for this study, these are all University of Minnesota patients. We had 28 patients total. 17 of those were PTLD patients, and 11 were immunocompetent patients who had primary CNS diffuse large B-cell lymphoma. Okay. That was our cohort. We looked at H&E and original immunostains. We tried to do a really careful morphologic analysis of these cases by grading the necrosis and describing the pattern of involvement, perivascular, diffuse, or both. We made sure EBV had been performed on all cases, or we went back and did it if it had not. And we did additional immunohistochemical stains, which are similar to those that were performed in the other PTLD study we had just finished. So making sure we got the Hans algorithm, P53, MYC, and CD30. Here's an example of morphology that we saw in many of the PTLD cases, the primary CNS PTLD cases. We just have numerous atypical lymphoid cells that are CD20 positive and fewer background CD3 positive T cells. This is what we saw, the pattern we saw, the morphology we saw in 10 of those 17 primary CNS PTLD cases, and in essentially all of the de novo primary CNS lymphoma cases. We frequently saw a perivascular pattern. This is a different case showing some perivascular infiltration, and about half of those cases had necrosis. Something interesting we did see, so in 7 of the cases, the cases had what we called a T-cell rich pattern, which was just a little bit different morphology. So there were still atypical lymphoid cells that were intermediate to large, but there were fewer, and there were many more small background lymphocytes and reactive glial cells. Many of those background small lymphocytes were actually T cells, CD3 positive T cells, and sometimes it was actually kind of hard to find the CD20 positive larger cells. But we could find them in all cases. We were able to show B lineage, and they all had EBV positivity. We did immunohistochemical staining. We actually restricted those additional immunohistochemical stains to the cases that had the more diffuse B cell proliferation, because the T cell rich pattern, you just couldn't tell. It just wasn't, you could not interpret the IHC staining on those cases. So we just did the IHC staining on those cases that looked more like the typical monomorphic DLBCL. These are just showing primary CNS PTLD cases on the left, the primary CNS lymphoma cases on the right. All the cases of primary CNS PTLD were CD30 positive. We just were unable to do the stain in case 13. None of the primary CNS PTLD cases, primary CNS lymphoma cases were CD30 positive. Only one of the primary CNS PTLD cases was MYC IHC positive, whereas 8 of the 11 of the primary CNS lymphoma cases were. The clinical differences between the primary CNS PTLD and the primary CNS lymphoma, the patients were younger with primary CNS PTLD by about a decade on average. All the PTLD cases were EBV positive. None of the primary CNS lymphoma cases were positive. Other than that, there were no differences in the clinical features or in the morphology between the two. So in terms of this, the primary CNS PTLD cases, we found some things that were confirmatory. They were not new. They were known in the literature, and our cohort matched that of the literature, in that they were all EBV positive. None had a germinal center immunophenotype by the Hans criteria, and most were CD30 positive. Something that was a little bit new that we thought we were able to bring to the literature is this T-cell rich pattern. We thought was worth emphasizing because they were harder to diagnose and harder to pick out that they actually were the atypical B cells in the atypical B cells in the T-cell rich background. Interestingly, only one of the primary CNS PTLD cases was positive for P53 by IHC. And that's a similar rate as we saw in the EBV positive systemic PTLD from our prior study. So that association of P53 negativity with EBV positivity persisted into the CNS. Interestingly, only one of the primary CNS PTLD cases was MYC IHC positive, which is different from the prior study. I don't know if this is a difference in interpretation because we were dealing with quite small brain biopsies at that point, or if there's something different in the mechanism there, in the pathogenesis. We did try to look for prognostic factors, but did not find any. Again, few cases and treatment was not uniform. So how do we do at answering my questions? So our cases of primary CNS PTLD that we excluded from the original study were quite similar to those reported in the literature. Maybe you're more often to have a T-cell rich background when it occurs in the CNS. They're all EBV positive, and they appear to stain similarly to the EBV positive systemic PTLD. And then primary CNS PTLD and de novo CNS large B-cell lymphoma have some similarities, some differences. They certainly have very different pathogenesis, so the differences are not unexpected. And that was actually, that's the reference for that, if anybody is interested. Okay. So my talk does have part of the title is Future Directions. And so some other questions that I have asked is prognosis, germinal center versus not germinal center, probably not, but we certainly need more cases. How often does MYC rearrangement really occur in PTLD? Outside of the context of Burkitt lymphoma, it doesn't seem to be very common. It would be nice to have a real answer to that. Interestingly, so in cases of de novo or DLBCL arising in immunocompetent individuals, it's maybe a third of the cases that have a TP53 mutation. Every single one of our EBV negative DLBCLs did. I don't know why. It's interesting. Further therapy, further thought. CD30, targeted therapy for CD30 is actually really exciting in this context. Most of the cases that were EBV positive were CD30 positive as well. Like I said, we have targeted therapy for CD30 now, and there's at least one clinical trial I found which is actually using upfront rituximab, so anti-CD20, and brentuximab, anti-CD30 therapy as first-line therapy for CD30 and or EBV positive large B-cell lymphomas, including PTLD. So I think that'll be really interesting to see where that goes. Okay. I just mentioned it in passing, but we did have a subset of cases where there was a discordance between the EBV DNA circulating DNA, so EBV circulating load, and the EBV status by EBR in situ hybridization of the lymphoma itself. There were a handful of cases that were discrepant, both directions discrepant. And is it a difference in testing, or is there something different actually about the biology of those particular PTLDs? And then another interesting question, and again, we're getting into smaller and smaller number of patients, but what about the patients who don't respond to therapy and relapse or refractory? I mean, there must be something different about that. Or one would think there's something different about the pathogenesis and about the biology of those lymphomas. And what can we learn about that? Okay. So what are your ideas? What are your questions? Mike?
When you compared P53 IHC to the mutational status that you did with Angus with how well did overexpression of P53 IHC correlate with mutational status?
It did pretty well. I don't have like the positive predictive and negative, sensitivity and specificity numbers for you. It wasn't 100%. We definitely had cases that were mutated, but were P53 negative and vice versa. It was pretty similar to the literature out there about how well it performs at P53 as a surrogate for the mutation.
So I don't know the literature about P53 in large B-cell lymphoma, but is there any utility in using it in kind of standard prognostication of DLBCL?
Yeah, that's a good question. And there are definitely studies out there that suggest that P53 overexpression does portend a worse prognosis, but it hasn't filtered down into being recommended for standard use. The 2016, those updates to the WHO, their main factors that they emphasize are the germinal center, the Hans criteria, and assessing for MYC. Yeah. Yes, Dr. Carson.
Protocols for use of immunosuppression in different solid organ as well as bone marrow vary a lot, and over the years they vary here. Did you find any correlation between the type of immunosuppression used and the development of PLT?
That's a good question, and we didn't look. Yes, that's it. Yeah, it was also, at least with the systemic one, it was between two institutions too, and over 20 years, 25 years. So those regimens definitely were variable between them. And that's your risk of PTLD, a patient's risk of PTLD varies depending on the organ that's transplanted, and a large part of that is due to the immunosuppressive medication necessary. So certain organs require more immunosuppressive medication or different immunosuppressive medication that can increase your risk. That's definitely an excellent question. I just don't know the answer to that.
Has there been a difference between use of anti-CD3 versus other immunosuppressors?
There is a literature on that too about which ones in particular are more likely to be the culprit.
Yeah.
Yep, there's definitely a literature on that.
You mentioned the EBV negative cases occur later.
Yes.
Transplant. What's earlier and what's later?
5 years. 5 years is about. And but the interesting difference is the CNS PTLD. Those definitely occur later, but they're all EBV positive. I don't quite understand that.
And another question, and I don't want to offend John Crossan, who has a superhuman immune system, but when chronologically in age do you start seeing this age-related senescence of the immune system, and when do that cohort of people start to look like immunosuppressed?
That's a good question. I don't know the actual cutoff, what an immunologist would call that cutoff. That's a good question. I know when we there's an entity, EBV positive DLBCL of the elderly, and they use 50 years old, but I don't think that's related to the immunosenescence picture. But that's a good question. I don't know exactly what year, your levels start varying. Yeah, I think a lot of people took offense to that. Yes?
So has anyone actually gone back, so you mentioned within your ways that PTLD is treated that there are a significant subset that basically respond just to removal of immunosuppression. Has anyone ever tossed out the morphologic or the other WHO classifications and just looked at the biological differences between those that respond to removal of immunosuppression or lightening immunosuppression and those that do not require other therapies that are, I would classify as more conventional chemotherapy type regimens for malignancies? Has anyone done like a transcriptional profiling or any of these markers or mutational profiling of just that?
Just their response. Not to my knowledge. I think part of the difficulty with doing that, I totally agree, it would be interesting. I think part of the difficulty is a lot of these early lesions, and maybe even polymorphic, sometimes they don't get biopsied. And that's getting more and more when we... Yeah, but it really does, and I think with PTLD, it's such a spectrum morphology, it's such a spectrum of behavior that making broad conclusions, whether you're making a conclusion about EBV or prognosis, is you really have to look at what did they include in their study. And I think that would be the difficulty, is that there'd be a whole chunk of them that you wouldn't see because they weren't biopsied. So yeah, that's an excellent point. All right. Well, I love showing pictures of my colleagues, so there's another one, and I hope everyone has a really great Wednesday.